Hello, everyone. Welcome to the third annual International Interprofessional Case Competition. I am Erica, and today we, Team 9, are excited to take you on a journey into the collaborative healthcare approach of our client, MT. Let's begin by acquainting ourselves with the dedicated individuals at the forefront of this challenge, MT's healthcare team. From left to right, meet the brilliant minds on our team.
Hi everyone, I'm Zainab.
My name is Onine Chukwumerjeni Bojina, and I'm representing the nursing profession.
Hello everyone, I am Ashad and I'll be representing the pharmacist.
Myself, Erica, representing occupational therapy.
Hi, I'm Shibla, and I'll be representing physiotherapy.
And finally, the guiding force behind it all, Dr. Faroki, our esteemed advisor. We will now transition to our table of contents, a roadmap that will navigate our presentation today. As a team, we've strategically selected Canada as MT's home of residence, influenced by our diverse perspectives. Canada's healthcare system aligns perfectly with our goal of providing MT with the highest standard of care. In Canada, the healthcare system is decentralized and publicly funding, ensuring universal access to medical services regardless of financial status. This is crucial for us as it allows us to fulfill our commitment to offering MT the best possible care. Within Canada's healthcare system, there's a strong emphasis on collaboration among healthcare professionals. This ensures a comprehensive approach to MT's diagnosis, where everyone works together to provide the best possible insights and care. Moreover, Canada's healthcare system prioritizes preventative care, meaning we're not just focused on treating MT's current condition, but also planning for our long-term well-being. This strategic approach aligns with our commitment to providing holistic care for MT. Now let's transition to our physician and team lead who will guide us in understanding the unique healthcare needs of our client, MT.
Hi everyone, I'm Zainab, the team leader. So our patient is MT, who we saw in the ICU. She's a 50-year-old Canadian female who presented to the emergency department with a complaint of severe headache, vomiting, and lower limb weakness. She also complained of blurred vision and difficulty speaking, with no previous history of similar complaints and no history of fall, dizziness, or syncope. She's a known case of controlled diabetes as well as hypertension, had a surgery of her lumbar disc problem in 2020, and multiple oral health problems. According to her social history, she's a heavy smoker but doesn't drink alcohol. She has a family history of diabetes and her father died due to myocardial infarction at 57 years of age. She lives alone currently, but her family are nearby and works as a waitress. Physical examination revealed that the patient is confused. She has ptosis in her left eye, lower limb weakness with a right limb power of 1 out of 5, and her left lower limb power is 5 out of 5 with bilateral brisk reflexes. Vitals are normal except for the blood pressure, which is 160 over 100 millimeter mercury. MRI confirmed the diagnosis of acute ischemic stroke, and the patient was transferred to the ICU. Patient was managed with a dual antiplatelet therapy, and our pharmacist will elaborate more upon this. Lab test mostly goes with the diagnosis of acute ischemic stroke, except for B12, which is highly elevated. Additionally, carotid artery Doppler was done, and it showed an atherosclerotic-related eccentric plaque along the anterior and posterior aspect of bilateral carotid bifurcation with significant luminal stenosis. Looking into MT's case, this is how we categorized her problems. Starting with the acute problems, which include the acute ischemic stroke, and here are the list of the complications that we discussed, and the prevention of each of the following complications is going to be discussed by the team members. Moving on to the chronic health concerns, which MT has 4 main chronic health concerns, starting with the diabetes mellitus, hypertension, coronary artery stenosis. And each of these complications, the complication of each of the following conditions are listed on the slides, and the preventions of these conditions is going to be discussed by the team members. Then we have her oral problems. So MT suffers from multiple oral health problems, which include the oral candidiasis, gingival bleeding, tooth 70s caries lesion, and enamel erosion. I would like to mention that we don't have a dentist or a hygienist in our team, but we try to do our best in order to manage MT's problems. Here are the short and the long-term complications of each of the oral health concerns. Moving on to the acute management plan. So after discussing with my team, this is the acute management plan. And these are, starting with investigations, these are some additional investigations that we'd like to add. Starting with the B12, we would like to repeat her B12 test since it is highly elevated, check her lipid profile, check the HbA1c, and do an ECG and echo to rule out atrial fibrillation. About her carotid artery stenosis, we would like to discuss it with an interventional radiologist to decide upon the management of her stenosis. Now, I will hand it over to our nurse to continue our acute management plan.
So moving on to hypertension, where we're going to monitor the blood pressure for any increase of more than 160/100 millimeters per mercury. We're going to administer Janumates every 12 hours to stabilize the blood pressure for the first 24 hours in order to reduce bleeding. We're going to monitor for a drop in pulse of lower than 64 beats per minute, which can indicate a brain damage. And we're going to continue to monitor the respiration rate to maintain it between 16 to 18 breaths per minute. High respiration can indicate increased intracranial pressure. Next, diabetes. We're going to continue to monitor the glucose level to maintain it between 5 to 8 millimoles per liter, because hypo or hyperglycemia can mimic an ischemic stroke, which can mislead the interdisciplinary team in terms of diagnosis and mess management. We're going to continue to administer insulin 4 units subcutaneously every 8 hours to stabilize the patient's glucose levels. I will now hand over to the pharmacist in our team.
So in regards to MT's medication management, here's a full list of the medications she's currently taking. We will implement several interventions accordingly. Firstly, we will conduct medication reconciliation, wherein we gather a verbal medication list from MT and compare it with the information in her medical records to identify any discrepancies and resolve them effectively. We will evaluate whether the current dosing regimen of Humulin regular is suitable for effectively managing her acute hyperglycemia based on MT's insulin needs and blood glucose levels. We will stop betahistine as an unnecessary medication with no apparent indication. Unless MT complains of vertigo, it will be discontinued. We will lower the dose of lisinopril temporarily till MT is stabilized. Since there are several medications and drug-drug interactions that only mandates monitoring, we will monitor renal function, blood pressure, bleeding tendencies, and muscle function accordingly. For venous thromboembolism prophylaxis, given that MT is on dual antiplatelet therapy and has experienced a minor ischemic stroke, we will not use pharmacological agent. Instead, we will initiate intermittent pneumatic compression therapy starting at admission if it was within 72 hours of onset. Now I will leave it on to our occupational therapist.
In this crucial phase of MT's healthcare journey, our focus is on developing a comprehensive strategy to ensure her overall well-being in the ICU, tailored to occupational therapy considerations. Diligently monitoring of vital signs, respiratory function, and pain levels is complemented by coordinated efforts with the interdisciplinary team to address fluctuations and ensure psychological stability. Holistic well-being from an OT perspective encompasses not only pain management for physical comfort, but also specializes interventions to support MT's occupational goals. This now will transition to our physical therapist to delve into MT's acute physical therapy intervention.
Positioning MT is a crucial part of her recovery as she has just experienced an acute ischemic stroke, which means she has a lower limb weakness and she's most likely to be bedridden. As you can see, this is some positioning that me, along with our occupational therapist and our nurse, are going to be placing MT along with pillows and supportive devices to prevent MT from experiencing pressure sores, muscle stiffness, and respiratory difficulties. For my acute management, I would start by doing an initial assessment, of course, collaborating with our physician and our pharmacist to know any side effects that MT can experience while doing an initial assessment or an exercise. Moving on with early mobilization, passive range of motion exercises, balance and coordination exercises, and mobility enhancement and functional training. Now I'll be handing it over to our physician.
Moving on to our chronic management plan, starting with the oral health concerns. So I would, as I said before, that we don't have a dentist or a hygienist in our team, but we tried our best, keeping in mind that we have to team up with a dentist and a hygienist to provide an optimal care for the patient. Starting for the oral candidiasis, we would like to give her an oral hygiene instructions, antifungal, and refer her to a dentist. Keeping in mind that candidiasis could be due to poor oral hygiene or immunocompromise, and immunocompromise could be due to the diabetes or other underlying conditions. Then we have the inflammation and infection, which include the gingivitis. Would give her oral hygiene instructions, refer her to a dentist or a hygienist for periodontal examination and full mouth debridement, addressing the relationship between tobacco use, oral hygiene, and diabetes, all with the gum disease. For the enamel erosions, we would like to take a full history and check the medications. It could be the result of GERD, and the GERD could cause enamel erosions. And referring her to a dentist for GERD and oral health counseling and management. Finally, for the cavity, we would refer her to a dentist for restoration or root canal treatment. Now I will hand it over to our nurse to continue our chronic management plan.
Here we have the long-term care of MT, starting off with the patient health education. The patient, primary caregiver, and family will be educated on MT's different medical conditions and their risk factors. After suffering a stroke, it affects different body systems such as the bladder and bowel function, speech difficulty, potential disabilities, and regulating emotions. This is where our in-house OT and PT will take over. Next, we move on to exercising, where the nurse is going to learn the exercises that the OT and PT are teaching MT and practice these exercises with MT and the family member that will be the caregiver. This will involve the family and educate them on what is needed to help MT in order to recover under the process of professional guidance. Next, we have family health education, where the 2 discharge options will be explained to the family and MT. The first one being that she can be put into a nursing home where they can accommodate MT until she feels better. Or she can go to a family member's home and have a primary caregiver assigned to her from the state. The pros and cons will be discussed with the family member. Next, we have the primary caregiver, where on discharge, the primary caregiver will be educated on the needs of the patient every day for the next few weeks. The caregiver and the nurse can develop a timetable with regards to eating plans, catheter changes, and exercises to improve the quality of health. Since the patient is in Canada, MT can request for a volunteer caregiver that will be most cost-effective and helpful for emotional recovery. The family member can also request for this. Next, we're going to move on to regular monitoring. We'll continue to regularly monitor the blood pressure and glucose and teach the caregiver how to do this and administer the medication. I'll now hand over to our in-house pharmacist.
When it comes to the patient instructions and medications at discharge, we will advise MT to keep taking the dual antiplatelet therapy, which is aspirin and clopidogrel, for the upcoming 21 days. And after that period, we will switch her to only aspirin 100 milligrams once daily indefinitely. We will evaluate MT's blood pressure, and if it was higher than the goal by 20/10 millimeter mercury, we will consider adding another medication, amlodipine, in the form of lisonorm tablets. These tablets contain both lisinopril 10 milligrams and amlodipine 5 milligrams, aiming to enhance adherence. We will evaluate MT's requirement for pantoprazole after discharge through consultation with the physician and nurse. This assessment will involve testing for gastroesophageal reflux disease and conducting a comprehensive history assessment. We will continue other medications like Lipitor, acetaminophen, Genemet with the same doses on the slides. In addition, we will ensure that MT receives a comprehensive medication counseling. This includes educating her on the significance of each medication, stressing on the importance of adherence, providing guidance on what to do in the event of missed doses, instructing her on proper administration methods, like taking aspirin with food to avoid any gastrointestinal discomfort. Additionally, we will counsel MT on the potential side effects and when to promptly contact her primary care provider. This includes advising her to report any signs of bleeding, such as bruising or dark stools, muscle weakness and pain, or consistent swelling to her physician immediately. We will collaborate with the physician, nurse, and dentist to deliver effective smoking cessation counseling and support. If MT responds positively, we will discuss and start nicotine replacement therapy, as quitting smoking is crucial for reducing hypertension, preventing periodontal diseases, and boosting hair immunity. The dentist will also contribute at this point by emphasizing on the importance of both flossing and brushing her teeth in preventing gum diseases and candidiasis. Finally, a patient information leaflet containing our contact information will be provided, ensuring that MT has a direct point of contact for addressing any questions or concerns regarding her medications. Now, I'll leave it on for our physical therapist.
Chronic rehabilitation for MT starts with an initial assessment again to check how far she has progressed from first when I saw her in the ICU. Moving on to mobility enhancement, which consists of, again, early mobilization and bed exercises, collaborating with occupational therapists and our nurse to ensure MT safety. And again, managing her pain with visual analog scale, educating MT about the importance of exercising her recovery process, setting SMART goals for her recovery journey. Later on, as she discharged, we will be prescribing her some home exercises along with our occupational therapist to align exercises with her ADLs. Lastly, providing MT with our support group or any support group that our hospital can provide. Now, I'll be handing it over to our occupational therapist.
MT's occupational therapy plan begins with an initial evaluation utilizing a communication device to accommodate her conscious but confused state. Recognizing the challenges of the dynamic ICU environment and MT's current symptoms, only one formal assessment will be utilized, the AMPAC, focusing on measuring support and task difficulty. This assessment will be complemented by clinical observation to thoroughly evaluate MT's cognitive, behavioral, visual, and physical aspects. The initial evaluation will be concluded with collaborative goal setting with MT and her family. As we transition to MT's intervention plan, designed with the top-down approach, our focus is on splinter skills. In close collaboration with the physical therapist and nurse, the focus is on the medical model and actively involving MT in activities of daily living. This includes addressing critical aspects such as pressure sore prevention, deep vein thrombosis management, contracture prevention, optimizing positioning, and effective pain management strategies. Anticipating MT's discharge from the ICU, the intervention plan aligns with our goals through a combination of therapeutic exercises, targeted neuromuscular re-education, and comprehensive strategies encompassing activities of daily living and client education. Additionally, we will integrate the incorporation of durable medical equipment or assistive devices as necessary to further support MT's transition and enhance her independence beyond the ICU. All right. This involves actively involving family members in the therapeutic process and tailoring our support to meet MT's nutritional and dental needs, recognizing their impact on her daily activities. Early discussion on post-ICU rehabilitation and recovery goals include specific strategies to enhance MT's functional abilities and promote independence. This proactive approach facilitates clear communication with MT and her family regarding her ongoing care. Our commitment to a comprehensive care plan is evident through the incorporation of OT-specific considerations, emphasizing infection prevention protocols and dental hygiene practices to address not only immediate concerns, but also long-term occupational well-being. I will now hand over the presentation to our esteemed physician and team lead, who will delve into the crucial aspects of interpersonal collaboration.
In presenting our collaborative efforts for MT's care, I want to highlight our current team compositions, which include essential members such as the primary care physician, nursing staff, occupational therapist, physiotherapist, and a pharmacist. While these key roles are crucial, we acknowledge the potential benefit of further enhancing our team. Specifically, we aspire to include a social worker, a dietitian, a psychologist, and a speech language pathologist. Our goal is to foster a truly multidisciplinary approach, ensuring a cohesive and comprehensive strategy that unites healthcare professionals, patients, and their families. We are resolute in our commitment to delivering a holistic care for MT. Interprofessional education is essential for healthcare professionals to develop collaborative skills, shared decision-making, and a holistic approach to patient care. Building interprofessional competencies enhances communication and enables professionals to navigate complex healthcare scenarios, ultimately improving patients' outcome. Interprofessional education fosters a collaborative spirit, breaking down a disciplinary barrier for cohesive and effective healthcare delivery. Now, moving on to the group reflection.
Now let's explore our group's reflection on interdisciplinary teamwork. In our collaborative journey, navigating time zone differences presented a significant challenge. Coordinating suitable meeting times across various regions initially felt like a puzzle. However, with persistence and adaptability, we successfully found an appropriate time for all group members. This challenge not only strengthened our scheduling skills, but also taught us valuable lessons in flexibility and cross-cultural collaboration. It has enhanced our ability to work seamlessly in a global context, showcasing the power of overcoming challenges through teamwork and adaptability.
Our team encountered the challenge of navigating diverse models when addressing our patient's condition. However, we overcame this obstacle by actively valuing and understanding each other's perspective while prioritizing a patient-centered approach to reach an effective solution.
Juggling between academic and competition was challenging, especially with students from diverse healthcare specialties and various countries, each with different exam schedule. Finding a suitable time that accommodates everyone was a challenge, and this marked the beginning of the challenge in allocating time for both competition preparation and academic responsibilities. When I participating in this competition actually shifted my perspective of my career. Collaborating with diverse healthcare professionals revealed how each individual approaches patients from a different and unique standpoint, emphasizing the significance of collaboration and effective communication. Selecting team members based on their expertise and understanding the reason behind those choices emerged as a crucial aspect.
Another significant challenge we encountered was the communication limitations. Relying heavily on electronic tools like email, WhatsApp, or Zoom interactions posed a stark contrast to the clarity and immediacy of face-to-face communication. However, I believe that we all learned the critical importance of values and ethics in the interprofessional collaborative practice. We realized how important it is to match our personal moral principles and ethical standards in order to handle MT's case as a unit.
Next, we have the roles and responsibilities and the role of the dentist. We learned that each discipline has a significant role in the recovery of MT, and that it's important to be patient and explain different concepts that are not familiar to other disciplines. We learned we can switch into each other's roles and have a clearer picture of what each discipline does in their specific field. Like our physician and pharmacist who stepped in as temporary dentist students to explain the dental plan for MT. We all worked together to fill in the dentist gap when we had to.
Thank you all for joining Team 9 on this exploration of collaborative healthcare for MT during this year's 3rd Annual International Interprofessional Case Competition.